Thank you very much. We'll now move to the last part of our opportunity to hear public comment. And I'd like to invite the 13 individuals who signed in expressing an interest in making public comments to please come to the mics. Again, there were about 13 of you who signed in outside of this room indicating an interest. And we'll also be hearing comments from individuals online. Sue Hassmiller will be sharing those comments as she receives them, and I'll intersperse those, calling on Sue about every second or third point along the way in terms of hearing from speakers to share those comments from individuals online. I want to underscore that each of you who are going to be sharing your perspectives in this section have 2 minutes, and we'll be adhering very closely to those time limits in order to accommodate everyone given the availability of time that we have this afternoon. So thank you very much, and just a reminder, if you'd share with us your name first and affiliation, and then share your thoughts. We'd be most appreciative. And I'll start here. We'll rotate back and forth and inclusive of the folks online. So please.
Thank you. My name is Dr. Edna Cadmus, and I serve as the co-lead for the New Jersey Action Coalition. I am faculty at Rutgers University School of Nursing and the executive director for the New Jersey Collaborating Center for Nursing. In 2016, we launched a model to help educate and engage nurses with community partners. We have recruited nursing coaches across the state to help us engage nurse volunteers. Educating them on how to look at data, how to connect through our portal was crucial. We formed an advisory board consisting of key organizations such as AARP and CVS that help move our work forward. We've worked with the Mental Health Association in New Jersey and others to conduct mental health first aid training to over 268 school nurses and 60 older adult community members. Mandating youth mental health first aid should be a requirement for all school nurses at a minimum. We have also supported training nurse faculty trainers with the goal to reach all nursing students. We place graduate leadership students into community organizations for their practicums to learn how to navigate in the community where they learn how to work in unstructured settings. They are able to provide data analytics and coordination skills that are needed for these community projects. A population health seminar series has been piloted with both practice and academic partners. This is being rolled out to faculty and practice partners across the state. We are now taking our skills and knowledge that we have learned over the last several years to try and leverage community and state resources to assist in one of our counties with the lowest county health rankings in the state. This requires boots on the ground. While nurses have volunteered their time in order to move to a healthier New Jersey, we need to create positions and an infrastructure in each county to link resources to consumer needs. This requires an infrastructure to prevent fragmentation of care. While their resources may be available, linkages between and among community organizations and the consumers are limited. Infrastructure beyond traditional structures need to be focused on more acutely. We ask the committee to focus their efforts in this area. Thank you.
Thank you very much. Yes?
Hi, my name is Bev Nierenberg. My company is Wellness at Your Fingertips, and I'm incredibly excited to be here to present this. When we look at the future of nursing, you have to consider burnout, self-care, which is a lot non-existent, overwhelm, stress, and I think those are very high issues that need to be addressed for them. So, and when we're stressed, as you all know, the sympathetic nervous system is engaged. And wouldn't it be amazing if we had something that could take us into the parasympathetic nervous system effectively, quickly, easily? Well, there is. So I'm here to tell you about it. It's something called Emotional Freedom Techniques, also known as EFT tapping. And it's evidence-based. It's a self-administered healing technique. It's a combination of 5,000-year-old acupuncture, but without needles, and some modern psychology, exposure therapy, and cognitive therapy. It's non-invasive. It can be done anytime, anywhere. Nurses can do it on patients as well, which empowers them at the bedside. And it's very easy to learn and do. So is it being used anyplace? Well, it is. So I don't know what happened to Dr. Cole, but my company is a connector in Healthy Nurse, Healthy Nation. And we have a page on my website set up for them, so it's able to teach nurses very, very quickly and easily, provide them with hundreds of free resources online to help them to learn how to tap. I have taught this at many hospitals, most notably Cleveland Clinic. I'm getting nervous. The Veterans Affairs Department has approved tapping to treat PTSD. That was a big thing that just happened this last year. I teach it at a special program at Kaiser Permanente. I know somebody on the committee is in Kaiser. I'm a member of Kaiser. I love it. It's fantastic. There's over 100 scientific and clinical studies that are
I'm going to have to say
available.
thank you for your comments. Apologize for having to interrupt, but thank
Okay.
you. And yes,
Thank
next.
you.
Thank you very much for this opportunity to comment, and thank you for all of your work and contributions in this effort. My name is Cynthia Sylvia. I am a recent graduate of the doctoral program at Cardiff University in Wales, and I am now managing member of a consultancy. The Institute of Medicine report of 2010 was the cornerstone of my doctoral research. The research, which was initiated with an intent to explore the identity and the role of the nursing specialty, the wound ostomy and continence nurses who have chosen a career in the medical device industry. It was initiated with the intent to explore that role and to provide a foundation of evidence for initiating discussion on the territorial boundaries of the role. The nurses are now established within the context of the medical device industry, and their future legitimacy and jurisdiction depends upon a strategic approach to navigate their journey. Social interaction positions them as leaders with unique skill sets to broker networks, span boundaries, and perform the labor necessary to transform geography that was historically considered a frontier. An agenda for the future will address 5 areas. First, to contextualize their role. Next, to expand the professional scope of practice. To normalize their identity in this new role. To build social context and cohesion, and to market their social front, the way they represent themselves. I call for future research on this role and the labor of nurses who are working within the context of industry and beyond.
Thank you very much for your comments.
Thank you.
Appreciate it. And Sue, let me go back to you now.
Yeah, thanks, Mary. I'm going to read 2 at a time because they're going to go quick here, and there's a lot in our audience out there. Comment number 1, if there's a name, I'll read the name. If there's not, it's anonymous. This first one is anonymous. There is a great deal of acute care related questions on NCLEX. How can this be changed to focus on more population health, the culture of health, determinants, etc.? Nursing education needs to also prepare students to pass NCLEX. There is conflicting emphasis. Comment number 2 from Jennifer Knowlton. While I appreciate the change of states, Nurse Practice Act to allow for expansion of scope within the healthcare, nurses have an opportunity to truly practice nursing outside of traditional healthcare structures. I would appreciate seeing this group consider how to expand the reach of nurses into further areas of our society and understand the value of public health and community health. These are areas where nurses truly provide nursing care, instead of only carrying out medical orders.
Thank you. Yes.
Hello, my name is Rebecca Love. I was the first director of Nurse Innovation and Entrepreneurship at Northeastern University and now serve as a strategy officer of Rialto. And the reason I'm here today is that I'm gravely concerned about the future of nursing. In the United States, we have nearly 4 million nurses. The average age of a nurse is 50, 70% of our nursing workforce is over the age of 40. But perhaps the most concerning statistic is that 57% of our new nursing graduates are leaving the bedside within 2 years of practice. And I believe that is showing that there is a fundamental failure in our current educational system, as well as an understanding of what is the business of healthcare. The truth is that when I speak to nursing leaders across the country, they have no idea that when they graduated nursing school that nurses were considered part of the cost structure of hospital systems, which means that they're not revenue generators, so a seat at the table wasn't naturally given to them. We have a major PR crisis in the world of nursing. Johnson & Johnson did a study that showed although we're the most trusted profession in the world, very few people outside of nursing understand what we do as nurses. Florence Nightingale founded nursing by challenging the status quo. She led medicine out of the dark ages of medical practice by challenging that what you could not see did not exist. The future of healthcare is only going to be changed if we embrace nurses as innovators, give them a seat at a table, and give them the business skill set to transform the future of healthcare. Today, you have an opportunity to redefine what nursing looks like, not only today, but in 100 years from now. I encourage this coalition not to look at the nursing issues that existed 10 years ago, but where we're going to be in 50 years, and design this coalition to reach there. Thank you.
Thank you. And over here, please.
Is that on? How does one follow that? My name is Dr. Cindy Sikora. I'm the Vice Dean of Practice and Engagement at the UT Health School of Nursing in San Antonio, Texas. I greatly appreciate the opportunity to be here and engage in this process. It is very exciting to see the strides that we've made in since the release of Future of Nursing 2010, but I believe there is much more work to be done. I've been overseeing community activities for nurse-managed models of healthcare delivery since 2010. First working in Newark, New Jersey in public housing, and now in San Antonio, Texas, where my team works in schools, childcare centers, clinics, and most recently a recovery residence for opioid-dependent pregnant and parenting women. Registered nurses in community-based healthcare settings make a difference in the health of populations. We demonstrated this in Newark and now in Bexar County, Texas, where women and children suffer the worst health disparities in the country. Nurses have been the most trusted profession for 17 years. Registered nurses with an understanding of the social determinants and cultural nuances of the communities they serve are able to bridge the gap between marginalized populations and our sophisticated healthcare system. I've been advocating for the role of registered nurses in community healthcare delivery for more than a decade, but it has always been with soft money. That cannot sustain our model. Our predecessors demonstrated that nursing can improve health of populations when nursing is able to do nursing. The Future of Nursing supported all professional nursing working to the top of their licensure, with much attention given to the critical role of APRNs in primary healthcare delivery. I don't believe that has changed, but I think that we need to put more of an emphasis on the role of the registered nurse, and we need to figure out how we're going to pay for those registered nurses to make changes in the community. Thank you.
Thank you. And over here.
Good afternoon. My name is Kenya Beard. I'm the Dean for Nursing and Allied Health Sciences at Nassau Community College in New York. As stated multiple times throughout today's session, diversity is not just a good idea. It is a critical imperative for the health of our nation. The last Future of Nursing report echoed the importance of diversity. However, research supports that the dearth of people of color in nursing persists, and the diversity ideals have been thwarted by factors that range from the academic achievement gap to disparities in employment, tenure, and promotion practices. My research has supported prior studies that revealed the disheartening fact that still today, the color of one's skin continues to be linked to stereotypical views that sometimes lead to negative outcomes, suboptimal treatments, and poor outcomes. The IOM Sentinel Report on Equal Treatment highlighted that even we who espouse to be empathic and altruistic can sometimes treat patients differently and unknowingly contribute to inequities in patient outcomes. As you can see, the cost of diversity recommendations without policies and consequences has proved to be high and failed to move the diversity needle beyond it being an important thing to do. My hope for the next Future of Nursing declaration is that the committee members allow the changing demographics of the United States and the political climate to embolden them to raise the question, What are the collective practices in nursing that disadvantages some and privileges others? And to make research-based recommendations on what should be done along with the importance of consequences. Diversity and inclusion is complicated, and no, nursing is not a panacea for all that ails society. We were asked earlier, what can nursing do? Nursing can lead as exemplars in the critical need to diversify our profession and make the ability to become a nurse, nurse practitioner, educator, tenured professor, supervisor, chief nursing officer, or board member a reality for all.
Thank you very much. Sue, do you have comments? Sue, do you have comments?
Yes, 2 comments, one from Joanne Banks. Please say something about what is being discussed with respect to ensuring that nurses are adequately prepared to competently address the needs of LGBT and non-binary people and increasing integration of transgender people into the profession. Another from Cindy Russell. Thank you for your very important work. Will the committee consider how nursing will be engaged to support the digital changes our society faces and how nursing will have a voice to inform technology-enabled healthcare delivery? As technology becomes ubiquitous, how can we assure some communities will not be left behind?
Thanks, Sue, for sharing those. Yes, here.
Thanks. Good afternoon, everyone. My name is Dr. Beth Taylor. I'm the Acting Chief Nursing Officer for Veterans Health Administration. I have the honor of supporting the practice of over 100,000 strong in our nursing corps as they deliver care to our nation's heroes. In our health system, we provide health care in all 50 states and several territories. So what we're finding is that as healthcare migrates out of the hospital to telehealth, to web-based care, to texting to our veterans, the state lines and in some cases international lines are evaporating. We have to consider our state practice acts, however, as we deliver our care and establish protocols for practice. So I would ask this committee to consider how we might minimize and or eliminate the barriers to a standardized scope of practice for nurses as we provide care without state lines or international borders. Thank you so much to the committee for what you're working on.
Thank you. And over here.
Speak. I am Executive Director of the National Association of School Nurses. School nurses work at the intersection of health and education with the population of children and adolescents. Students experience home and community factors that enhance or limit their health and education. School nurses collaborate with students, families, educators, community health providers, community leaders, and community agencies to complement the strengths and to meet the needs of students. What we'd like for the committee to remember is that children are often hidden, and certainly their care within the school building between 8 and 3 is unknown to many, even their primary health care providers. We need to remember as the committee works that there are other groups that need to be involved in the care of children. Even a child who is abandoned is not alone. They have a guardian. We need to remember that they live in homes, hopefully, unless they're homeless, and they eat food, and they need all of the supports that any adult needs. Remember the children.
Thank you very much. And here?
Hello, my name is Michelle Mahan. I'm a registered nurse leader and a nursing practice representative with National Nurses United. NNU is the nation's largest professional association and union of registered direct care nurses in the United States of America. I am here on behalf of our membership who has already been leading the charge to make change in the social determinants of health by connecting climate justice, social justice, economic justice, and racial justice through sweeping educational programs of our membership, as well as advocating legislation. We are now the proud winners of the nation's strongest workplace violence protection standard, and of course, the only state in the nation that has guaranteed minimum standards for nurse-to-patient ratios. We have heard so many things here today about how nurses are the essential voice and partner in the future of this commission and this discussion. However, notably absent in the last commission, and unfortunately it appears again, is the voice of direct care nurses. We cannot plot the future of nursing without our voice. We know we are experiencing burnout in epic proportions. People are standing before us questioning why. Nurses collectively have been shouting out, we already know why. It is not a failure to be resilient, but rather unsafe working conditions that are leaving our patients and ourselves behind. The unjust and immoral structure of healthcare in the United States that sacrifices our patients and all healthcare providers at the expense of profit. The values are skewed, and it is time for us to take a step back as a profession and make that analysis together.
Thank you very much. Sue, do you have some additional comments online?
From Merrick Moen, how will funding models, in parentheses, reimbursement, fee-for-service, and other, end parentheses, support nurses to grow or go back into the field beyond the tertiary settings to address individual, but especially population health where we are needed? Can you describe good models that are not temporary, grant-funded, that support and recognize the critical value of nurses in these spaces? The decline in funding for public health nurses is not encouraging. Second comment, anonymous, education and research, interprofessional endeavors, RWJF funding, explore the possibilities of designate funding specifically for team-based projects, promote nurses as co-investigators, elevate our nurse scientist, related inquiry practice equity. Why is dedicated research time only for physicians and training fellows? How can your organization best address these concerns? I think that's for everyone. I see that it's for RWJF, but I'm just going to make that for everyone.
Thank you very much. Yes.
Hi there. Happy spring, everybody. I'm Lexi Abelin. I am a staff nurse. I do work at UPMC Pinnacle in Harrisburg, Pennsylvania, but I'm not here on behalf of my workplace. I'm here because I'm a staff nurse. And a lot of times in many of these discussions, I look around the room and I'm sure there's a lot of nurses here, but I just wonder how many are, on that front line working. Everything I wanted to say, I wanted to actually cut right through and make a quick comment on something I saw on one of the slides about reducing disparities. And I just want to say that in 2010, Healthy People 2010 decided to change that language. They said, no, we're not just going to reduce disparities, we're going to eradicate them. And I feel like it would be a disservice for the committee to ignore that, and I think that that statement about reducing disparities needs to be immediately changed to eradicating those disparities. That being said, I'd also like to amplify all the voices of color who are here, and also that comment from online from someone saying that we as nurses need more training and investment in understanding how to serve LGBTQ and other population. I am a diploma nurse. I was a single mom and found a way into nursing through an evening weekend program. I wanted to do that and go right into nurse midwifery, but there was huge barriers as far as expense, and it's been a huge journey. I just wrote my last paper for my BSN program at Aspen University. Thank you. I finished that yesterday morning at 3 a.m. Pacific Standard Time. And I just want to say Aspen University has a model of payment that would make accessible.
Thank you very much for your comments. Appreciate it.
I'm Virginia Saba. I'm a nursing informatics expert, and I want to urge the committee to make sure that we get technology into the report widely. First of all, the reason that we're having trouble is that we don't have any coded data on nursing at the federal level. There's not one nursing database at the federal level, so they do not know what we do. That's my major issue with what's happening today. And so we've got to get together, we've got to select a terminology, and we've got to become, like everyone else, like all the physicians, we ought to have an ICD for nursing and an ICD CPT for nursing. Thank you.
Thank you. Yes?
Hello, my name is Stacy Sutton. I'm also a staff nurse. I work at John Randolph Medical Center in Hopewell, Virginia, and I'm also in a BSN program to better myself in the world of nursing. I'd like to comment today. I'm looking forward to this committee's report and on the subject of nurse retention and job satisfaction. One of the things that I see we have a small community hospital. I work with the best bunch of nurses. I couldn't have asked for a better crop of well-trained, wonderful people to work with. And I see one of the things, I'm a co-chair on our professional practice council, and one of the things that we constantly see is a wide disparity against customer satisfaction survey reports and the actual comments we are getting from our patients on the nursing side of things. I don't think those scores accurately reflect what we do as nurses for our patients, because what we hear from our patients is, oh, this is a great place, you gave the best care, you really, explained things to us, and then we are told by our administration our scores aren't good enough. And, it's very hard to hear at the end of a grueling 12-hour shift when you feel like you've given 150% to come back and hear that it's just not good enough. And I think that's one of the things, me being at John Randolph Medical Center, I've only been on our unit for 2 years. I'm one of our senior nurses on that unit. So I've precepted RNs from our STAR RN program, our new RNs that come in, and I'm seeing wonderful things from that residency program, but I still fear for the longevity of floor nurses and being able to motivate them and lift them up.
Thank you very much. Sue, do you have additional comments?
Dr. Cynthia Sotelo, what will the committee be reviewing and doing to support the removal of practice barriers that have been imposed on nurse practitioners in those states that are still restricted in their practice? Angela Stahlbaum, I have a great passion for the geriatric health and population. I very much hope this will be included as a vulnerable population. As nurses, we must be prepared to care for this population in acute care as well as outside of the acute care settings. As nurses, we must learn how to advocate for this population that includes the resources directed to this population.
Thanks. Yes.
My name is Dr. Rita Dowse from Johns Hopkins School of Nursing. I am a certified nurse educator and an incredibly proud nurse practitioner. The outcomes of the Committee of the Future of Nursing for 2020-2030 will be profound in establishing a course for our country. As a result of that, I ask the committee to consider the impact that we live in a global society. We cannot consider the health of a nation without considering the impact of a global society, whether through migration or other components. Many times I find my patients tell me, I die because I can't afford to live. And so as we consider the intersection of policy, I would like us to think it's not the full practice authority that's the issue. It's what can be authorized to be prescribed as a nurse practitioner versus not, what is recognized. But also that it is, although it costs less to keep somebody in a home, because it is not covered, they become institutionalized or moved out of their home. So as we think about these, to consider Last is the impact of our digital revolution going on, and that we are not keeping up in education necessarily with practice, nor is that being used for remote areas or homebound. Thank you for this opportunity.
Thank you. Sue?
We'll take one more in person, and then I have a couple of comments, and then we're going to...
That'll be it. Okay, great. Thank you. Yes.
I'll be quick. My name is Erin Kyle, and I work for the Association of Perioperative Registered Nurses. The comments that I'm about to make are my own. I've heard a number of things today, and I've picked up on a couple of them, and I really want to support those comments. One being that we need to focus on identifying and eliminating barriers to healthy living in the environment. And when I say environment, I don't just mean the physical environment, but also our digital environment. So we all know that there are either unhealthy or unhealthy environments, or we're sending the wrong message within our environments, meaning digital advertising, et cetera. I just want to call that out because I think that we have an opportunity for some policy to help restrict that. And secondly, I'm not sure of your name, but you said that nurses were very alarmed to find that they were part of the cost structure. I think that that's something that we should not breeze over. That's something that is extremely important and is probably at the root cause of the burnout issue that we're seeing.
Thank you very much. Sue?
This is from Lindsay Huth. I hope I'm pronouncing that right. Thank you for the opportunity to give input to this vital process. I have a couple of comments. First, more support and resource capacity for nurses who specialize in public health would be extremely helpful, since these nurses are the experts in addressing the social determinants of health and comprise one of the largest segments of the public health workforce, yet they are frequently the least supported and cope with massive research shortfalls while doing their best to mobilize communities to care for all populations. Even within the broader nursing profession, public health nursing is sometimes not well understood or supported. Second, if we expect all nurses to work towards building a culture of health, all nurses need a true understanding of the upstream drivers of population health, health equity, and the social determinants of health as a foundation to all nursing work. This should start at the very beginning of a nurse's education and be integrated throughout that education and be a vital topic, including on the NCLEX. Additionally, these concepts need to be taught by faculty who actually are working expertise in these subject areas. Whether a nurse is at the bedside or in a community setting, they need to understand where and how a disease process starts in order to innovatively address it. And that its genesis is not necessarily in the patient's body. Our brothers and sisters who are caring for patients in acute care settings can barely keep up with capacity now and are shouldering tremendous burnout. It will take all of us looking through a population health and prevention lens to slow the tide. Shaping that lens starts on day one. We can do this if we do it together. I have one more, Dr. Wakefield, a very short one. I'm going to do this. No. Anonymous, could there be consideration to include a voice from the military community? Thank you, Dr. Wakefield.
Thank you very much. And thanks to all of the folks who participated, both listening online and also provided comments, and to those of you who were in the room and shared your views as well. And I'll hand it back to the co-chair.
I just want to say, on behalf of the committee and on behalf of the National Academy, a profound thank you to each of you for being here today. I want to thank the presenters for providing us with very valuable information. I want to thank the attendees and the viewers for their excellent comments that we've received and their interest. We want to remind you again to sign up for our listserv so that you can receive notice about future open sessions. There'll be other sessions around the country where there will be opportunities for you, and others that you can let them know about our committee will have an opportunity to provide input and information to the committee. We are really looking forward, as we do this work, to learning more from you at future meetings. Again, thank you very much for being here today.